And now let's move into our first leadership discussion of the day. Please welcome our panelists, Chintan Patel, Head Information Technology, Shrimad, Rajchandra Hospital and Research Center. Can we have a huge round of applause? May I also request Mr. 𝗕𝗂𝗶𝗴𝗶, Group CIO, 𝗕𝗂𝗰𝗀𝗃 Group and Hospital, 𝗗𝗂𝗰𝗱𝗃𝗃 Group DGM, 𝗕𝗂𝗃 Hospitals, India. Can we have a huge round of applause for all our panelists? May I also request Mr. Vipul Patel, IT Head, the Gujarat Research and Medical Institute, Rajasthan Hospitals, 𝗕𝗰𝗸𝗃 Contractor, DGM Information Technology, 𝗕𝗂𝗰𝗱𝗃 Hospital, GIFT City, Deepak Tully, co-founder and COO, 𝗕𝗂𝗃𝗃, Anup Arora, founder and CEO, 𝗓𝗐𝗏𝑑𝑜𝑠 Infosystems Private Limited. And moderating this session, Saneesh 𝗕𝗰𝗁𝗁𝗃, Head Information Technology, Apollo Hospitals International Limited, Ahmedabad. Please welcome our panelists and moderators with a huge round of applause.
Now, all are our senior as well as very veteran panelists. It's so difficult to plan anything in healthcare, not even healthcare technology. 10 years planning is too much. Let us speak about 3 years or 5 years. In fact, even in my hospital, we have seen 3 or at least minimum 2 times we are replacing our desktop system in 10 years span. So planning for 10 years would be too difficult at government level as well as Avinash sir, those NABH level, let them plan for the next decade. We being in hospital, let us work for a year ahead and at least maybe 5 years. So straightforward, let me jump into my responsibility of putting the questions. Before putting the question anyway, I need to set a context also. At the cost of duplication, I was part of one of the earlier panel of DHN, and I will pick a earlier example where I was mentioning that in one of the forum it was asked, आप अभी Zepto में या Big Basket में you order anything, it comes at 5 minutes, 10 minutes. तो आपका ambulance क्यों नहीं आता? This was some haunting question, probably worth mentioning. So 10 मिनट में नहीं आते, 15 मिनट में नहीं आते. We have our own answers, but customer expectation, patient expectation has been grown. We need to respond that way. Second thing, recently I was reading a news. गुजरात की इंश्योरेंस बिल है, हॉस्पिटल की इंश्योरेंस बिल, एवरेज बिल कॉस्ट अराउंड 1.3 lakhs, sorry. So पैसा तो देना नहीं है, and you need to have a better quality service delivery. So these are the contradictions we are living in. Now, as healthcare leaders, there are eminent people to drive all those business, but we as the typical IT walas generally doesn't get forums to express any of our thoughts. So let us attempt what we have in our mind. So starting with Chintan bhai. Chintan bhai is a veteran from a trust-based hospital with a huge capacity. He is driving most of the digital initiative there, and we always look upon him, a very veteran. मैं आपको ये पूछता हूँ, तो you given a chance, आपको पूरा digital backbone rebuild करने, either in your hospital or in another hospital, और trust hospital है. Trust में तो हमेशा ऐसा बोला जाता है भाई पैसे का चिंता मत करो, बराबर? But I don't know how much they will sanction. But you get a chance with enough budget to build a digital backbone. So what all your mandatory priority and what you will keep aside? भाई बाद में करेंगे, please.
Good morning, everyone. First of all, I welcome DHN to Gujarat, and I also want to say in Gujarati કે DHN તમારું ગુજરાતમાં હાર્દિક સ્વાગત છે. So, as mentioned by Saneesh bhai, ट्रस्ट हॉस्पिटल में क्या होता है मैं आपको बताता हूँ. बजट तो है लेकिन आईटी के लिए नहीं है. अगर आप ट्रस्टीज को बोलोगे कि मैं अगर ये एक इक्विपमेंट्स लगा दूंगा और इससे मेरे इतने पेशेंट को बेनिफिट होगा तो वो इक्विपमेंट तुरंत आ जाएगा. लेकिन मैं बोलूँगा कि मुझे एक फायरवॉल चाहिए या ये चाहिए क्या मुझे और ये इम्प्लीमेंट करना है, तो उसमें मुझे पूरा ROI देना पड़ेगा। और ट्रस्टी उसको ट्रैक भी करेगा कि ROI देने के बाद आपने मुझे बोला था कि फर्स्ट मंथ में इतना रिटर्न आएगा, वो इतना रिटर्न आया कि नहीं आया। ओके, सो आई जस्ट मूविंग टू माई टॉपिक, and if we have to build the digital hospital, so as per my experience, what we have done at Shrimad Rajchandra Hospital and Research Center, Dharampur, as a IT head, my goal is not technology. First, I have to assess the entire workflow of clinical and the operational. Once I cleared my workflow, then I can start 4-5 things. Which one? First is I can say reliability. कि अगर आपको डिजिटल हॉस्पिटल बनाना है तो आपके यहाँ स्ट्रक्चर, रिलायबल स्ट्रक्चर होना चाहिए, जैसे कि नेटवर्क, सर्वर, पावर बैकअप एंड डिजास्टर मैनेजमेंट, सिक्योरिटी, ये सारी चीज़ें होनी चाहिए. So I will make first sure that our reliability should be there. So my first goal, we have to establish the entire resources with the resource properly. Otherwise आप कोई भी बड़ा AI टूल डालोगे या कोई भी अच्छी सी एप्लीकेशन भी डालोगे, अगर नेटवर्क प्रॉपर नहीं है, इंटरनेट कनेक्टिविटी प्रॉपर नहीं है, तो उसका रिजल्ट आपको नहीं मिलेगा. सेकंड पॉइंट आएगा इंटीग्रेशन. सो फर्स्ट डे से मैं सारी चीज़ें इंटीग्रेट नहीं करना चाहूँगा, जैसे कि AI, डेटा एनालिटिक्स और ये सारी चीज़ें. फर्स्ट वी हैव टू अंडरस्टैंड द वर्कफ्लो ऑफ डॉक्टर, नर्सिस, फार्मेसी, बिलिंग, रेडियोलॉजी, पैथोलॉजी, एंड those few things I will start with it. एंड सेकंड लॉट में जो एडिशनली है वो एनालिसिस और AI के बारे में हम लोग सोचेंगे. Third thing is most important is data security, cyber security and data protection. So digital hospital के लिए data security and cyber security is most important. So उसके लिए हमें proper security भी होना चाहिए, disaster management, backup facility भी होना चाहिए, और trend logs और बैकअप प्रॉपरली होना चाहिए. ये सारी चीज़ें डे 1 से ही होनी चाहिए. अगर आप डिजिटल हॉस्पिटल कर रहे हो तो उसको आप बाद में ऐड नहीं कर सकते हो. थर्ड पॉइंट इज टू स्केलेबिलिटी, कि अगर आप वॉट एवर यू हैव बिल्ड टूडे, इट शुड बी सपोर्ट द रिक्वायरमेंट ऑफ टुमारो. जैसे कि हम लोग ने हमारी हॉस्पिटल में डिजिटल फ्लो इम्प्लीमेंट किया, उसके बाद हम लोग ने NABH किया 2 साल के बाद. NABH करने के बाद नेक्स्ट ईयर हम लोग ने डिजिटल NABH किया प्लेटिनियम कैटेगरी में. उसके 1 साल के बाद हम लोग ने NABL एक्रेडिट किया, और NABL के साथ साथ ABDM भी हम लोग ने इम्प्लीमेंट किया. ABDM भी वी हैव M1, M2, M3 एंड नाउ करंटली वी आर वर्किंग फॉर M4 एज वेल. सो स्केलेबिलिटी भी होनी चाहिए कि डिजिटल में जो आज आपने इम्प्लीमेंट किया है, इट शुड बी सपोर्ट फ्रॉम टुमारोज रिक्वायरमेंट. नाउअडेज वी आर वर्किंग विद द NHCX एज वेल. सो वो कैपेबिलिटी भी आपके सिस्टम में होनी चाहिए. एंड फिफ्थ इज वेरी इंपॉर्टेंट पॉइंट इज सीक्वेंसिंग. सीक्वेंसिंग इज वेरी इंपॉर्टेंट. एज पर माई एक्सपीरियंस, वी शुड हैव टू create the digital workflow. Once the workflow is complete, we have to connect the workflow, and after that make your workflow intelligent. So as Saneesh bhai, as per my question, I am giving you the perfect answer is that कि अगर मुझे digital backbone hospital बनाना है तो बेस में मुझे मेरी resources proper होना चाहिए. So it was my based or building structure. And second, I want to connect application, and then on the top of it I will implement the AI or dashboard, live dashboard or analytics. So as per my view, we have done the same thing in our hospital as well. First of all, we have implemented HIS, PACS, RIS, everything. Then we will start other application as well. And currently we are working with some another AI tool, just like voice to text. And also we are in the tribal and charitable hospital. So we have 6 outreach van. So every day, one doctor, compounder, pharmacist, and driver with one ambulance, they are going to the doorstep to the village people. We offer them a medicine service by free of cost. So those entire data we are taking digitally, capturing digitally during the outreach. So at the time of registration, the patient is registered under the application. Afterwards, we are taking the vitals. So vital also taking digitally. Then the doctor take the entire EMR records, which is complaint, diagnosis, examination, everything EMR should be is in the digital. Afterwards, the pharmacist also dispense the medicine to the patient. So every data which we are getting from the outreach, all are the digitals. So benefit, what benefit? I am just going to show you that okay, when the van come from the outreach to the hospital, so van automatically string those data with our production server. So when the patient need hospitalization or during the outreach, our doctors found that this patient is required the hospitalization immediately or referring to the hospital. So when the patient come to the hospital, our doctors can see entire record of the outreach, which is collected by the doctors over there. So when patient come to the hospital, doctors can see entire journey of the patient.
Correct,
So
correct. So in fact, इनको बोलने दिए तो मैं I was asked by Aarti that you should control all your speakers. It's very difficult to control it. But I have learned, let me quote from one of his earlier conversation, may not be in the interest of HIS vendor. He said he has made it mandate as a part of contract. NABH digital, any certification comes, those complaints has to be free. That was a very interesting take. Anyway, I will be moving to Rakesh Bhai.
thank you.
Thank you, Chintan Bhai, for your elaboration. Rakesh Bhai heads IT of Pramukh Swami Medical College, Karamsad. A very noble place. I worked there for 4 or 5 years earlier. It's a very unique hospital. The very classic point we insisted him to be come on forum and share his experience is that probably that would be only one hospital, at least in Gujarat, I am sure, having an open source HIS, complete open source HIS, database, PHP, everything is complete. Then it is an in-house team. This combination rarely you will see. Now, I will ask Rakesh Bhai how probably this would have started, and as of now, I understand they are very able. Nilang was there for close to 15 years, responsible for the infra delivery. As of now, I understand they are reached to a stage of good adoption of EMR also. It's a very classic case. So I would leave to him, but please share your experience that we can take it from that.
Good morning, everyone. And thank you to DHN to give me an opportunity. Thank you to give me an opportunity for DHN to give me this. And I'm the first time coming like this panel, and I'm representing for the first time. And this is a last door entry. Basically came to me and just given you talk about something on what is your journey on open source. So it is actually a last 3 decade journey. We started in 1996. I was not there, but whoever was earlier, they started software running on Fox Pro and Novel Network at that time. Novel Network and Fox Pro at that time. At that time, we started with only registration, billing, and pharmacy. That's a standard practice at that time. If you have only these 3 things, then your hospital is running, everything is fine, nothing, no problem. So I think in the 2000, they started adopting open source technology using a PHP. And they are using a LAMP stack at that time. And still we are currently using a LAMP stack till date. So, still we are maintaining that 5 to 6 key members in our team for last 20 years. And they are actually running the show of actually maintaining and improving the existing HMS. We call our EMR called SOLACE. It stands for SOLACE. Sri Krishna Hospital for Clinical Excellence. SOLACE. And actually it controls each and everything, every flow, everything. And through that product, basically, we are getting so many accreditation like NABL, NABH. Recently, we received platinum level NABH digitization. There are a number of products we have received. I don't want to name it. But the basic beauty of the product is that, anyone suggests some changes, we quickly give them the solution.
Correct.
Now, if you have some outside vendor, if you give one request, after 3 months, you will never get any update after that. They will say that we have a CR, we have these things on timeline. So many things comes up, but this is because we also experience that the same thing. So I'm just giving you the reality. This is what happening when you are when you have a in-house development team, then you can adopt the things, you can adopt to the most of the business requirement, and other way around is also that, when you have something very, we get very quickly, and there is a lot of ideas will come to you, basically to the IT department saying that, you do this, we need in this time, there is a lot of pressure will come. But, in that, how we can tackle it. So only, we adopted 4C approach. One is the first thing is clarity. Then second one is basically you connect. If you connect appropriately with the team members or the appropriate stakeholder, then you control the things and then you conclude.
Correct.
If you adopt the 4C's approach, then I think most of the problem will be sorted out. And the fifth C is a communication. So if there is no communication gap, then all your problem will be sorted out. Whether it is any IT related problem, any business problem. That approach we are actually using it here, and we don't see any major issue with it. Sometimes comes up, business requirement change, that's a normal. Today you will come to say that I need this, I need this, I need this. You freeze the requirement, you did everything. After you go to production and then say, no, sir, we want this now. Now we have to adopt the change and we have to modify the software accordingly, we have to release it.
So that is fine. In fact, I just want to compliment, as of now, any IT manager, any leadership, you give a chance to develop an in-house IT team. They may not be so comfortable for that idea. This hospital nurtured the team, maintained the team. He is there for 15 years. And I was fortunate enough to be in the initial stage of development, and I was very much active part. And this hospital was the first medical college to get certified for enable that with the same software. So this is a kind of thing this would be a good case study for any maybe DHN. I think I would recommend that they should participate in that. And they are not a very showy kind of people, but but we have some interest. Somewhere my name should also get printed in that.
Thank you, sir. Thank you.
Thank you, Rakesh Bhai. Further, 𝗕𝗂𝗀𝗃𝗃 Namaste. So now 𝗕•, he represent 𝗕•, hospital. Yes. That is the probably those who are in Ahmedabad, in and around Ahmedabad. Next big thing probably going to happen in Ahmedabad. Very much eager. I am sure that you will be receiving a couple of CVs from here. So, we know that 𝗕 want to take a corporate shape in a very quick fashion, and if you want to have the volume of business operation, you must be obviously heading the group. You will have your own standardization agenda.
Yes.
But as far as I being in one of the unit, we want our own liberty and experiment with innovation. How you are going to manage this?
Yeah, of course, sir. Actually, in my point of view, everything should not be controlled by the centralized. Something should be liberal at the unit level also. For an example, IT infrastructure, architecture, data protection, security, endpoint security,
Correct.
like that can be managed by the centralized. But something related to clinical decisions and operational level at a patient point of view, it should be handled by the unit level.
Okay.
Yes.
Any specific points you are giving as a directives to a new unit? Do you set up a template for a new unit? IT standard thing should be like this, anything of that sort?
Yeah, actually we have sent a standard SOP.
Okay.
So based on that only we are implementing every new hospitals. Actually we are a growing hospital across pan India.
Correct.
As of now we are in 7 centers across the India. So in around 27, we will have in around 28 places.
Oh, that is a huge growth potential coming up. Guys, ready with your CVs? Thank you, Shakti Velan. Vipul Bhai is a veteran of the city. Very few people who healthcare IT में हो या healthcare में तो विपुल भाई को नहीं जानते से बड़ा मुश्किल है. और मैं आपसे ये पूछता हूँ भाई, आपका भी ट्रस्ट हॉस्पिटल है, डजेंट मीन दैट ट्रस्ट इज समथिंग बैड और गुड. आई एम मोर फॉन्ड ऑफ अ ट्रस्ट हॉस्पिटल, क्योंकि द काइंड ऑफ गुड थिंग्स यू आर डूइंग. देर इज ऑलवेज ए बैकलॉग ऑफ लेगेसी, लाइक बैगेज ऑफ लेगेसी सिस्टम्स. आपको मॉडर्नाइज करना है तो पुराने सिस्टम्स चलता है, इट कुड बी एन इक्विपमेंट वट एवर जो सिस्टम चलता है, और उसको आगे ले जाने में व्हाट यूर चैलेंजेस आर, आपको क्या दिक्कतें पड़ते हैं?
गुड मॉर्निंग एवरीवन. पहली बात यह है कि मैं अहमदाबाद की फर्स्ट कॉरपोरेट हॉस्पिटल, इट इज़ राजस्थान हॉस्पिटल्स, 40 साल से है. और हम ऐसा बोलते हैं कि सिविल हॉस्पिटल में से जो डॉक्टर पास हुआ, फर्स्ट प्रैक्टिस राजस्थान हॉस्पिटल में करते थे. और आज अहमदाबाद के आगे पीछे जो भी बड़ी बड़ी हॉस्पिटल्स के जो भी ओनर्स हैं, वो सारे मतलब कि राजस्थान हॉस्पिटल से तैयार होके गए हैं. आई कैन से तेजस पटेल, विक्रम शाह, फिर 𝗕𝗰𝗗𝗃, सारे लोग. तो राजस्थान हॉस्पिटल एक ट्रस्ट हॉस्पिटल है, और वेरी फर्स्ट डे से वो थोड़ा थोड़ा कंप्यूटराइज हुआ है. लेकिन कंप्यूटराइज में ऐसा था कि मतलब कि सारा कंप्यूटराइज नहीं, नॉट इंटीग्रेटेड एनीथिंग्स. और धीरे धीरे डिजिटाइजेशन उन्होंने किया. अब डिजिटाइजेशन में टाइम में ऐसा हुआ कि मतलब कि मेरा जो पास्ट एक्सपीरियंस था, आई वॉज विद वन ऑफ द डिजिटल हॉस्पिटल दैट्स कॉल्ड द कृष्णा हार्ट. इट इज़ द फर्स्ट हॉस्पिटल विच इज़ फुल्ली कॉरपोरेट हॉस्पिटल्स आई कैन से. तो मैं वहाँ से आया, मैंने यहाँ पे देखा राजस्थान हॉस्पिटल में एवरीथिंग इज इन पेपर वर्क. आज मतलब कि पेशेंट को कुछ देना है तो पेपर वर्क से जाएगा, आज डॉक्टर को प्रिस्क्रिप्शन देना है तो भी वो पेपर से जाएगा. तो 2013 मेरा वहाँ पे जर्नी था, और देखा कि मतलब कि सारे वर्क्स पेपर्स में हो रहे. तो आई जस्ट एक एक डिपार्टमेंट को मैंने स्क्रूटिनी किया. स्क्रूटिनी करने के बाद एक जर्नी ऐसी आई कि नाउ वी हैव टू जस्ट ट्रांसफ़र एवरीथिंग इन द डिजिटाइजेशंस. लेकिन डिजिटाइजेशन का एक सोच ट्रस्ट के सामने लाना बहुत मुश्किल की बात होती है. कि आप ट्रस्ट को बोलो कि हमको ये डिजिटाइज करना है, तो बोले पहला तो एक वहाँ से रजिस्ट्रेंस आएगा कि भाई पहले से ये चल रहा था, तो आप क्या है, मतलब कि एक उनको एक दिखाई देगा कि कोई नया बंदा आया हुआ है. तो स्टाफ भी ऐसा था कि स्टाफ का भी रजिस्ट्रेंस था कि वो बोले कि डिजिटाइजेशन, हम तो यही मेथड से चल रहे हैं और बहुत अच्छा चल रहा है. यही मतलब कि जो गवर्नमेंट वाले जो पर्चे होते हैं ना, कि मतलब एक फाइल होता है, फाइल के अंदर सारे पेपर्स होते हैं, एक डिपार्टमेंट से दूसरे डिपार्टमेंट में पेपर लेके जाने का. सो मैंने ये सारा स्टडी किया. स्टडी करने के बाद अब बारी आई कि हाउ वी डिजिटाइज ट्रांसफॉर्मेशंस. सारा बंद तो नहीं कर सकते, क्योंकि वी आर इन द लाइफ सेविंग. अगर हम कोई भी एक डिपार्टमेंट को भी बंद कर लेंगे कि चलो आज इसको बंद करना है और डिजिटाइजेशन में ट्रांसफ़र करना है, तो अगेन एक प्रॉब्लम आ जाएगा कि वो इंटीग्रेटेड नहीं है. तो इंटीग्रेशन नहीं होने की वजह से वो डिजिटाइजेशन करना मुश्किल हो गया था. तो धीरे धीरे सारा हमने स्टडी किया, पूरे डिपार्टमेंट को, पूरी हॉस्पिटल के सारे डिपार्टमेंट को कनेक्ट किया. कनेक्ट करने के बाद स्टडी किया कि भाई कितने इक्विपमेंट्स कौन से डिपार्टमेंट में मैन्युअली चल रहा है, कैसे कुछ मशीन भी होंगे कि जो मशीन आउटडेटेड भी होने वाले होंगे, मतलब कि एसेट पॉइंट ऑफ व्यू, डेप्रिसिएशन पॉइंट ऑफ व्यू. कुछ मशीन ऐसे हो गए कि नहीं, हमको उसमें इन्वेस्टमेंट नहीं करना है, क्योंकि आज मैं मतलब वो मशीन को चेंज करना चाहूँगा तो वो मशीन चेंज भी नहीं होगा. तो डिजिटाइजेशन भी करना है और कुछ भी बंद नहीं करना है, दोनों साइलोस था कि कैसे काम करें. तो धीरे धीरे हमने किया कि कहीं जगह मतलब कि जैसे पैथोलॉजी लैब था, तो पैथोलॉजी लैब में इंटीग्रेशन करना है, तो मेरे HIS के साथ इंटीग्रेशन कैसे करें, क्योंकि मशीन इज़ वेरी ओल्डेस्ट वन. तो हमने कुछ बीच का रास्ता निकाला. तो जो बीच का रास्ता निकला वो मतलब कि कन्वर्टर्स. नाउ यू कैन गेट इट द कन्वर्टर्स वेरी वेल, कि आज मुझे HDMI टू VGA, VGA टू HDMI, बहुत सारे कन्वर्टर थे. तो कन्वर्टर का यूज़ किया. देन वी स्विच टू द मेरा डेटा मतलब कि धीरे धीरे कन्वर्ट होना चालू हो गया। तो ऐसे एक एक प्रोसेस हमने किया एंड 2019 में एक बड़ा स्टेप लिया, दैट इज द ओवरनाइट हमने पूरा का पूरा एक प्रोसेस स्टॉप करके पूरा डिजिटाइजर में ट्रांसफर किया। मतलब कि जैसे 1 अप्रैल 2019 दो स्लॉट में चल रहा था सिस्टम पूरा, कि पुराने सिस्टम में भी चलेगा और नई सिस्टम में भी, लेकिन जो नई सिस्टम थी ये फुल्ली डिजिटाइज एंड ऑल द डिपार्टमेंट इज इंटरकनेक्टेड, और जो पुरानी सिस्टम थी वो मतलब कि इंटरकनेक्टेड नहीं थी। तो सबसे बड़ा प्रॉब्लम था कि पेशेंट आर एडमिटेड इन ओल्ड सिस्टम्स, पेशेंट न्यूली एडमिटेड इन द HIS ऑफ द न्यू HIS। तो ये चीज़ करना थोड़ा मुश्किल रहा जब तक मतलब कि मेरा एक पेशेंट पुरानी सिस्टम में से आउट ना हो तब तक। नया सिस्टम में चालू हो गया सब कुछ, तो एक फेज था कि जहाँ पे हमने बहुत चैलेंजेस लिया। नाउ वी आर फुल्ली डिजिटाइज। आज बहुत सारी हॉस्पिटल ऐसी होगी कि जहाँ पे EMR नहीं चलता होगा। आवर हॉस्पिटल इज अ फुल्ली EMR कंप्यूटराइज, और आज डॉक्टर को बोल दिया गया है कि यू हैव टू नॉट यूज पेन और पेपर।
बहुत अच्छा है।
तो आज मेरी हॉस्पिटल में आज एवरीथिंग इज कंप्यूटराइज। डॉक्टर को मतलब कि डेस्कटॉप दिया गया है, लैपटॉप दिया गया हुआ है। आज मेरा नर्सिंग स्टाफ भी आज पूरे डेटा मतलब जितनी भी एंट्री है, वाइटल्स एंट्रीज है, मेरा पेशेंट्स का जो भी फ्लो है वो सारा, और मोस्ट अभी मतलब कि बिफोर 1 वीक वी स्टार्टेड ICU डिजिटाइजेशन, कि जो बहुत टफ चीज़ होती है कि ICU में मिनट टू मिनट उनका रिकॉर्डिंग होना चाहिए। तो सारा का सारा हमने डिजिटाइज किया हुआ है। फार्मेसी अभी एक प्रोजेक्ट अभी चल रहा है 2 दिन से, कि डॉक्टर प्रिस्क्राइब द मेडिसिन बट patient has to take the medicine prescription from my pharmacy department. So I will see the how many patients comes to my pharmacy department, my own pharmacy, how many patients reach to my radiology department, how many patients reach to my pathology department, and what are my OPD to IPD conversions. So day to day I get the reports कि इतना मेरा मतलब कि इतना फ्लो है ये सब कुछ। सो हमने ये सोचा था कि मतलब कि एक दिन में कुछ बंद नहीं करना है, सब कुछ साथ में रख के पेशेंट को कहीं सफ़र ना हो वो ध्यान रखना है। तो ये साइड में ऐसा भी हुआ कि आज कई सिस्टम ऐसी है कि आज मतलब कि बहुत सारे हॉस्पिटल में ऐसा सिस्टम चलता भी होगा कि कुछ सिस्टम विंडोज 7 पे चल रही है आज। सो बिगेस्ट प्रॉब्लम इज द सिक्योरिटी, कि विंडोज 7 में सिक्योरिटी कैसे अप करें। तो हमने मतलब कि क्राउड स्ट्राइक से बात की, तो क्राउड स्ट्राइक ने हमें ये बताया कि विंडोज 7 के पैच हम देंगे आपको। तो विंडोज आज बहुत सारी सिस्टम है कि जहाँ पे मतलब मुझे ज़रूरत नहीं है कि ये यूज़र को मुझे मतलब कि फुल फ्लेंज सिस्टम नहीं देनी है, वहाँ पे मैं विंडोज 7 पे भी चला रहा हूँ लेकिन विद द सिक्योरिटी। तो पुरानी सिस्टम को भी मैं कवर कर रहा हूँ साथ में, और नई सिस्टम जहाँ पे ज़रूरत है वहाँ पे नई सिस्टम भी रहे। तो ये कहना है कि मतलब कि पुराना रख के भी साथ में डिजिटाइजेशन किया हुआ है हमने।
Yes, yes. So it's a good blend of migration and retaining it. In the
yes.
interest of time, let me jump to भव्यांग, क्योंकि वो बाय हार्ट किया हुआ सीक्वेंस में भव्यांग का नाम आता है इसके लिए। भव्यांग, अभी आप गिफ्ट सिटी में यू आर स्टार्टिंग लीलावती ऑपरेशन, क्या एडवांटेज है आपको? नो डाउट वी नो सर्टेन एडवांटेज ऑफ गिफ्ट सिटी, बट व्हाट अदर एडवांटेज डिजिटली यू आर अवेलेबल ऑलरेडी हैव?
So, hi, this is Bhavyang from Lilavati Hospital, GIFT City. So, we talk about the traditional hospital approach where they have a legacy system, where they have old infrastructure set up, your building is ready, and your processes and policies are plain, and on top you have to set up your applications, you have to do integration and the automation. So that is quite challenging, what we heard. As a Lilavati, I think we have very good chance to showcase and to have a strong digital backbone infrastructure setup. Now, three things I want to cover in my topic. One is the strong digital infrastructure. The second thing is the integration, and the third thing is the future readiness for the hospital. So, talking about the digital infrastructure readiness, I think the GIBS city itself has a standardized international level backbone what they have set up, which is a kind of role model for setting up the hospital's infrastructure. Now, when we talk about the GIBS city's strong backbone, so all the buildings are interconnected through a strong fiber connectivity. All the utility services are being provided centrally through the GIBS city. So they have their own command and control center, which control all the critical services from all the buildings. So that is very good example when you talk about the digital connected buildings or the hospitals. So talking about Leelavati Hospital's infrastructure, I think the first thing is the digital infrastructure, and from GIBS City we have research, studied, and we learned how to set up a strong digital backbone for the hospital infrastructure. So for us, setting up the fresh, IT infrastructure in the hospital doesn't mean that you just have to set up the network. You have to set up the computer systems and start. You have to install few of the application and start, operation of your hospital. So you need a strong backbone which integrate with different, ecosystems. Now, the second thing is integration. Now, when we talk about the integration, there are two parts. One is the standard integration of all the hospital application systems. So, say for example, if you have 50 different application working in your hospital, and if it is not integrated, if it is not talking to each other, I think you may land up with the 50 different isolated digital islands, I think. So integration is very important, and in our case, I think we don't have to integrate our hospital information system and application, but we have to integrate our system with the centralized command control center of the GIBS city.
Okay.
So, integration of hospital systems like your HIMS should talk to your laboratory information system, radiology information system, your PACS. Your electronic medical records should fall into the digital information should fall into the EMR, and your management required analytical dashboard where they come to a decision making system, right? So that is the one thing where you integrate your internal hospital system. But in our case, I think majority of our critical application we have to integrate with GIBS City centralized command and control center. So that includes the BMS, your IBMS, your fire systems, then your access control, even your CCTV surveillance you have to share with the GIBS City command center. Even your parking information also you have to share with GIBS City's command center.
Take a let us
Yeah.
put a stop on that.
Yeah, sure.
It's very interesting to listen that.
Yeah.
Now coming back to Tuli sir. Now ABDM integration is everybody's top of mind, and even I was referring to that a number of ABA IDs registered in the country is close to 96 crores. It was surprising news for me even. So what are the challenges? We know that at least you are working with our company also as a tech partner. What are the typical challenges people expect, otherwise you come across in interfacing with HMIS?
Yeah. Thank you very much. I think I will just take it back to basic first principle. The fundamental problem in every hospital system which I see is that the input done by the physician is not structured. And that is the fundamental problem. Like we all use UPI today. I need to give you 10 bucks, you need to give me 10 bucks back. It's all structured, 10.00 and it's rupees and it goes into. Because that's so structured, data moves smoothly. For any hospital to have a right framework of integrating with anything, or having an analytics, like sir said, OPD to IPD conversion, you said technology changes, 10 years is not expected, things are changing in days now, In my earlier days, you used to say 5 years. Now I say 6 months is enough. Even at that stage, if the fundamental data input will not be structured, it will never happen. That's the biggest problem in health tech. There are no standardization in this country. Nobody follows any set of codes. So exchanging data between 1 to 2 entity becomes a challenge. It's a big challenge inside the hospital, even a bigger challenge outside.
Yes.
Be it's a pharmacy or a lab or a hospital data. So that's a big problem. Hospitals, legacy systems make it so hard for anyone to go ahead and do, smooth integration. Like ABDM, one of the compliances is that you have to send a FHIR object. How many system in this country works on a FHIR API, right? When we started off 5 years back, it was very hard for us to even find an engineer who's worked on FHIR.
Correct.
All of these guys have worked in US, and getting them to India was a cost expensive affair for a hospital, even challenging, right? So the problem needs to be solved from the core, right? Which is digitization at the core, and the problem becomes a physician entering, right? You can push the nurse, but how do you enter the physician? There are a lot of solutions now in the market, including one of ours. I think that's the biggest problem which needs to be sorted.
Okay, fine. So moving to further, Anup, maybe many of the people have in mind, suppose if you are setting up a hospital and looking for HMI solution, I am sure that you have this hybrid model, say that it can be an on-premises or a cloud. What you would suggest you would prefer to suggest either it's a cloud model or a on-premises model, typical hospital to come up?
See, if you ask me, it's totally on the call of your hospitals, but definitely as a HIS or LIS provider, we offer both the models. But definitely, if as a technical background, if I would say, the future is cloud, because the kind of facilities and the security and other things, scalability, you get in cloud, you will not afford it on your physical servers. And apart from that, I always think that hospital is a place which is meant for treatment of people, patients. So better doctors need to invest their energies and times in managing their treatment instead of developing HIS.
Correct.
Or managing these things. Better to outsource these things to the people who are meant for that. So this is the much better approach I always believe in.
That is fine. Anyway, we are running out of time. So we had an open source veteran, cloud experts, ABDM experts, Leelavati, a range of people. Can we take any question from audience, if at all something is there? Otherwise, yes, please, sir. Raju, sir.
I just want to, I'm very curious, I think Deepak raised a point where to reconcile doctors and the HIMS writing and all. I'm just very curious, is the government doing anything to standardize terminology for diseases? Like USA, they have something called as SNOMED, which has been given to College of American Pathologists. Like very simple example, congestive cardiac failure and congestive heart failure. They're the same things. But one doctor would write that and one doctor. How do you all reconcile this?
Deepak, sir, you can take it.
Yeah, definitely. If you go to NHA, they are putting all standards. Like for example, in the case of you said that SNOMED, then there is a line code for labs. But the problem is the systems have been so old, and every hospital have their own, databases. Every field has been labeled based on the fancies of the developer who was developing. I like CBC to be CBC. Somebody likes CBC to be CBD. Then it will be CBD. Then it goes forever because that guy at that time, maybe smoking something and did that. So there are rules, but changing fundamentally blocks and how much a hospital will be able to invest into the structure update is a big challenge. We follow all this global standard, and then now there are technologies to convert this. Even if you have a legacy system of converting, you can convert through AI technology. So,
yes, one more question, yes, please.
Hi, I'm Sandeep, Dr. Sandeep Patel from DocHub. We are a healthcare career platform. We used to connect with many doctors about the job posting and all, where we found that problem. But I'm sure that while selling a software to clinics and hospitals, you must be getting excuses from the doctors who are don't want to switch to the IT or adopting the technology, right? How do you solve these challenges? Convincing the doctor we still using the paper and no, while selling the software, I'm just asking this.
Anupji, you will take, otherwise, as a moderator, I will take the privilege. Please carry on.
Any panelist, I mean, that will be a good insight.
I think you were talking. See, there are challenges, but now after post-COVID era, the entire industry is changed. Now doctors, hospitals, laboratories, radiology, all must are aware. But definitely, a country like India, we have to look into a different segment. We have a doctors who are treating 100 patients in a day.
Correct.
And we have a doctor who treats only one patient in a day also. So as a salesman, you need to understand, it's not like that you have to educate them, you have to evaluate their need also, and you have to map them. But the best part in current scenario is the outlook towards IT and the adaptation IT tools, maybe it's AI based or HIS or legacy or LIS, has been totally changed.
Yes, right.
People start listening to you, and we are blessed that when we started, HIS is just a billing software, but now people realize the potential of HIS and they are ready to listen what you are saying. Maybe they are a head behind, they are not able to adapt, but they have different challenges.
Yeah, I will. Yeah, yes, sir. You are raising the hand. This last one, madam, please.
Yeah.
Please, sir.
My first submission to you that well, you are IT people and veterans here. How about the, DPDPA? Where are we?
I think
we are
Avinash
hitting
sir
with
will
the-
have
yeah,
too much
we are
thing
hitting
in
with
that
the
to cover.
November deadline,
Definitely.
and I don't hear that. Number one. Number two, about the data. Input. Very valid. I would say. Point, and that has to be addressed by ontology can really address this issue the gentleman has addressed.
Correct.
So that is where perhaps the AI integration would definitely take care of so many things. And AI today is, people think there's ChatGPT, but no, AI, we have to present a big challenge to AI. We have to challenge the AI so that the AI can really help us to get to where. And as doctors are learned people, so naturally adoption will be much
So
faster.
they only train us as of now. AI adoption के लिए, I don't brand doctors are hours of digital transformation or adoption. There are good set of doctors. They train us by अभी ऐसा करो. These are the good tools. You use this. They give us very good input. We need to gel with them. We need to try to speak their language. Let me close this. I think wonderful discussion. Probably good inputs. We will be connecting outside after this also. That is fine.